Hello, I'm Christy Griffith, Survivorship Navigator with the LUNGevity Foundation. I'd like to welcome each of you to today's virtual meetup. As always, this is our place, a safe space to learn, to grow. Any information obtained in this or any of our LUNGevity virtual meetups should never be taken as medical advice or guidance. We would encourage you to consult with your own provider. I am so happy to introduce another amazing expert. Today we have Dr. Jonathan Lischalk with us today. Welcome, Dr. Lischalk. Dr. Lischalk is board certified in radiation oncology, specializes in the treatment of prostate, lung, brain, and spine cancers. Dr. Lischalk serves as the medical director of the NYU CyberKnife Center at Perlmutter Cancer Center in Manhattan, as well as assistant professor and director of research for the NYU LI Department of Radiation Oncology. Dr. Lischalk has authored more than 30 peer-reviewed publications in a variety of oncology topics, including prostate, CNS, and lung malignancies. Welcome to our meetup, Dr. Lischalk.
Thank you so much for inviting me.
We are so happy to have you with us. As mentioned in our conversation, we have an amazing community of lung survivors. There is lots of excitement about your time with us for conversation today and discussion of all things CyberKnife.
I'm looking forward to it.
You bet. I'm going to keep an eye on the chat, and we'll let you know of any survivor questions that are posted or come up. Attendees, if you want to, if you would all please make sure that you're muted. And then if you'd like to raise your hand to ask a question, you can do that as well. Just let us know or post in the chat. Whatever's great for you works for us. Dr. Lischalk.
Well, thank you so much. I'm excited to be here. Obviously, any questions that come up, I have a few slides I'll probably walk through here since they've got some pretty pictures on there, and we'll go through these slides. But feel free to interrupt me at any point if you have any questions about radiation, CyberKnife, or anything that I'm talking about. Happy to pause and chat. Let me share my screen. Let's see here. Let me know if you can see my cursor in my screen. Is that visible? Okay, great. Well, you know, one of the things that I like to start off talking about is radiation. What is radiation? Because honestly, it's one of the, radiation oncology is one of the smallest fields in medicine. And getting radiation treatment, not only for a lot of patients, but even physicians that I work with day to day, is a little bit of a black box. It's a little confusing what actually goes on. And I think some people actually think I'm some type of James Bond villain here, that people get strapped to the table and then get radiation. But in reality, radiation has actually been around for a very long time. It was initially discovered in the late 1800s in Germany. And this is a really interesting story. A physician or a physicist discovered the X-ray, and within 1 year, this discovery translated into being used on the battlefield to remove shrapnel and bullets. It was used in operating rooms around the world. It was something that went from discovery to implementation, probably one of the most rapid medical advances that we've ever seen. And that's really where it finds its roots in 1895. And when we started using radiation therapy to treat cancer in the early 1900s, you know, our technology and the rooms that we used and the type of X-rays and radioactive particles that we used, they were really primitive. And if you looked at you know, an example of a radiation delivery room, it would look like something like this back in the early 1900s. Almost looks like that James Bond photo I showed, where it's this old, very old equipment on a table here. with no computers, just a sink in the background there. And if you juxtapose that with the machines that we use today and the patient treatment areas that we use today, very different experience. And so this is an example of a radiation room in 2021, and you can see that certainly come a long way in terms of this type of technology. Radiation oncology as a specialty really finds its roots in the middle of the 1950s when Dr. Henry Kaplan, who was a professor out at Stanford University, helped develop some of these early machines and implement their use in cancer, and specifically in Hodgkin's lymphoma, which was at that time the first time Hodgkin's lymphoma was cured with anything. It was cured with radiation. And so that's really where radiation oncology's story starts. And when we think about the two aspects to radiation oncology or radiation treatment that are important to understand when we're trying to get rid of a cancer, it comes down to two main things. One is physics and the other is radiobiology. And the physics of radiation oncology is interesting because we are able to achieve essentially what a surgeon can achieve, but without cutting through the body. And so how is that possible? Well, the reason for it is the utilization of the X-ray, which has a certain degree of energy. And as we all know, if we go get a chest X-ray, the film will be placed in our back and the X-ray will be coming through the front of our body. And so the X-ray is actually passing through your body. And if you use X-rays together and kind of converge where those X-rays are going to a certain to a certain area in the body, you can create this radiation cloud that can be very high dose. And if you put that cloud right on top of a tumor, you can achieve very similar results to what you see with surgery, but without cutting through the body. And so it's really the physics of radiation oncology that is so amazing, be able to achieve similar results without having to do an operation and going to get general anesthesia and removing a tumor. And that's one aspect to radiation oncology. There's an entire field of radiation physics that exists. But the radiation biology is the interaction that the X-ray will have with the tumor. And so once you've gotten those X-rays into that target or created that radiation cloud over the tumor, how is it getting rid of the tumor itself? Well, what's happening there is an interaction between the X-ray particle and the DNA of the cancer cell. And cancer cells have a lot of damaged DNA. And one of the things that makes a cancer cell so erratic is that it just grows uncontrollably. And one of the reasons it does that is because the DNA of that cancer cell is really just not able to operate properly. So if we have an X-ray hit that damaged DNA and cause even additional damage, because that DNA is already so messed up, it can't repair itself. And when it tries to divide again and do what a tumor or cancer cell is trying to do, it can't do it. And it essentially can't repair itself, and then it subsequently dies. And so there's this radiobiological interaction between the X-ray particle and the cancer cell DNA that's able to preferentially kill those cancer cells over normal cells that do have the ability, if they encounter X-rays, to repair their DNA and go about their business. And so it's those two arms in radiation oncology that really are able to achieve kind of the amazing things that we see. So let me show a picture of a regular linear accelerator. And this is just an image of a machine that we use to deliver X-rays. And so the patient will be lying on this table here, and the X-ray would be coming out of this machine here. And so this machine can rotate around this radiation table here and deliver X-rays at specific angles. And I want to show this picture because I think it's helpful to juxtapose a machine like this with the machine that we use at my center, which is the CyberKnife machine. So, what is CyberKnife? Well, it's kind of interesting technology that it is a misnomer. You know, there's no knife, there's no cutting, there's no pain, there's no anesthesia associated with this machine. But if you look at its the history of the machine, it was originally developed in the late 90s, early 2000s by a neurosurgeon out at Stanford again. And this neurosurgeon had a background in a specific type of radiation treatment called radiosurgery. And he wanted to develop a machine that could perform radiosurgery. But the linear accelerators, or that picture that I showed you previously, this is a machine that just simply couldn't achieve.
No, we don't even leave here till 1 o'clock.
That type of radio surgery that this physician was trained to do. So he developed and this machine to accomplish that. So what the machine is fundamentally is a very advanced robot, and this robot can basically come in at a variety of different angles. You can kind of see here the various positions that it can come in. This is a kind of like one of those robots you would see out in Detroit that was working on creating automobiles. This is like a $1 million machine that's able to kind of achieve all these different, very precise, minute angles and positions. And he took a linear accelerator and just mounted it on the front of that robot. And so it kind of took two pieces of technology and merged them together to create the CyberKnife. And that ultimately resulted in the machine that we see today, which is pictured here in this example. You can kind of see the remnants of that robot here, that robot that can kind of come in at different angles. And then here's the linear accelerator. And so I don't have a movie of this, but you could kind of imagine this thing coming in and rotating at different angles and bringing that X-ray in to kind of target, create that radiation cloud right around the tumor that is being treated. So when you enter a room like this, like in our facility, you would lie down on this couch or table. This machine would move over your body, kind of position itself so we've got the radiation beam in the right area. At the same time, there would be these X-rays that are being obtained. These are actually X-ray panels here on the ceiling that are generating the X-rays, and they're hitting this image detector. And the reason why they're in the room is they can monitor the positioning, so that when you're lying on the table and the machine is moving over your body, sometimes there's motion. And for lung cancers, there's a lot of motion because we're breathing during the treatments. And while that breathing is occurring, the tumor is also moving. And with those X-rays, it can monitor where the tumor is moving, and the machine can actually accommodate for it. So while the tumor is moving, the machine is kind of tracking it like this. It's a very advanced way to image during treatment to make sure that positioning is perfect. And so behind the scenes here in a different room is a serious set of radiation therapists and physicians that are monitoring the entire process here with fairly advanced equipment and making sure that tumor is being targeted very precisely. So that's just a little bit of background that I wanted to give before we open up the floor to questions. But that's the type of radiation machine that we use. That's a kind of some history behind radiation and the applications that we use in the modern era are pretty advanced and a wide range. So with that, let me open up the floor to questions.
Thank you, Dr. Lischalk. That is a great overview of CyberKnife. The technology is just beyond amazing. So grateful for that. So what patients are appropriate for CyberKnife?
That's a really good question. So the short answer is we use this to treat almost any disease site, any type of cancer, from cancer, brain cancer to lung to prostate. We're even starting to use it for breast cancer. But every situation is very distinct. And so when I see a patient, you really have to carefully go through the entire history, take a look at the scans and the imaging to determine if CyberKnife is the right technology for a given situation. So we use it for almost every disease site, every type of cancer, but it's not every single case, and it's not every stage for a given cancer. And so, so that's a conversation that's really important to have with your primary radiation oncologist or medical oncologist to determine if it's the right technology to be used in a given case.
You bet. And I see that we have a question in the chat. When is CyberKnife used in lung cancer versus SBRT or SABR?
Well, this is a great question. So SBRT or SABR are actually umbrella terms. They stand for stereotactic body radiation therapy or stereotactic ablative radiation therapy. They're a little bit used interchangeably, but there are it's an umbrella term. And one of the types of machines that's used to deliver that type of therapy is CyberKnife. And so for the most part, all of the treatments that we do for CyberKnife are ablative. So that means high doses of radiation over a short period of time. And so it's just a subdivision of the type of machine that you would use in those cases.
Thank you. Thank you. Another question is, I don't know if you got your eye on the chat or not, can a patient with stage 4 have CyberKnife? And then also the same question about when it's appropriate regarding proton therapy as well. I think that's what Alyssa's asking.
So the stage 4 lung cancer, I think, is what is being asked. CyberKnife can be used in those situations, but it really depends on the situation. So if there's lung cancer that's gotten into the brain, we very commonly will use CyberKnife to treat a cancer that's gotten into that area. Depending on where the cancer is spread and the amount, we will sometimes use SBRT or a SABR, delivering CyberKnife to different locations. In the modern era, our understanding of what stage 4 means for different cancers is different. And for many years, I think we have thought all stage 4 cancers were the same, meaning that the cancer has gotten out from where it started. And really the only thing that to be done at that point is
doing good.
So you are doing
is
good.
chemotherapy.
Get myself off of this call.
In the last 5 to 10 years, what we've realized is that there are certain types of stage 4 that we can be more aggressive about treating. If there's only a few spots here and there, sometimes we more aggressively treat those areas with radiation, including using a CyberKnife machine to get rid of those spots, because ultimately the outcome seems to be a bit better. And so the short answer to that is yes, we do use it for stage 4 lung cancer, depending on the location and depending on the amount. The follow-up question was related to proton therapy. So proton therapy is a different type of radiation entirely. CyberKnife uses X-ray based radiation, so it's an X-ray that's being used. Whereas with proton therapy, proton is a high energy proton that is directed towards a tumor. And in this situation, there's only a finite number of proton centers in the country, because they're actually very expensive facilities to build, oftentimes $150 or $200 million to create these facilities. And the physics of a proton is very different from an X-ray. And so it can be used for certain types of lung cancer. Certainly I've used it in the past, but it's really a different model entirely from X-ray based treatment. And the reason it's different goes back to, the physics and the radiobiology of radiation oncology. Well, the difference for protons is that the physics is quite different. And because of that, we use it for certain situations. For lung cancer, it's probably not used quite as much as it is for like pediatric cancers. Maybe there's a lot of pediatric brain tumors that we use it for, or cancers that are found in younger patients. What is the difference between CyberKnife and whole brain for small cell lung cancer, which is best? So again, another great question. It really depends on the situation. Certainly, whole brain radiation is something that we've done for many, many years, and it's a very effective treatment. But in the modern era, we've been trending away from using whole brain radiation because we use it when there's cancer in the brain and we just can't identify all of the areas that could be involved. And so we treat that whole area because if cancer grows rapidly in the brain, it can be very dangerous. And so treating the brain with the whole brain with radiation was something that was fairly standard. But as MRIs became more versatile, and as our radiation became more targeted, oftentimes we target just the areas that have that are involved in the brain rather than treating the whole brain. And so for many situations where there's only 1 or 2 or 3 or even slightly more numbers of cancer deposits in the brain, we'll use CyberKnife or radiosurgery to target those areas rather than treating the entire brain. And we think that this may help in reducing side effects that can come with whole brain. That being said, there are a lot of situations where we do still use whole brain treatment. Just to clarify, is Gamma Knife the same as CyberKnife? Another great question. So Gamma Knife was a technology that was developed in Sweden back in the 60s and 70s by a neurosurgeon. And it's a machine that basically has a radioactive source. It's a radioactive cobalt. So this is a source that's emitting radiation. It's not a linear accelerator where the radiation is created. It's actually emitting radiation. And to get Gamma Knife, you basically have a helmet that's attached to your head. And then you go into this machine, and the emitted radiation kind of is targeted to different areas of the brain. So the whole idea of CyberKnife grew out of Gamma Knife, except there are some very big differences. Number one, an X-ray is used rather than a radioactive source. Number two, rather than using bolts that go into the skull and immobilize the head during treatment, we use just a plastic mask. And number three, Gamma Knife is limited to treat cancers that are within the brain and just down to the second vertebral body, whereas CyberKnife can be used to treat anywhere in the body. And going back to that picture of the Stanford neurosurgeon I showed you at the beginning, he actually worked with the inventor of Gamma Knife, and his idea to create CyberKnife grew out of his understanding of Gamma Knife. So that's kind of a little bit of history there. Proton for single nodule in upper lobe. Again, tough for me to answer without looking at a given case. Proton is used for some lung cancers and certain stages of lung cancer, but it really depends on the situation. I would say overall, more commonly, SBRT is used for a single early stage lung cancer in a given lobe. Whereas protons oftentimes is not too much more beneficial in that situation. But there is expanding research in this area to determine if it is as effective or more effective than SBRT. How many treatments can one have over a lifetime? Is there an accumulative dose? Great question. So when we look at the candidacy for radiation, one of the first questions I ask a patient is, have they had radiation in the past? And it's very important to know if they've had radiation to the same spot, because doing radiation to the same spot a second time can be more dangerous. Now, it can be done, but it's only done in certain situations and really has to be carefully considered. Now, if the radiation is to a completely different location, typically it's safe. But it really becomes more of a concern if those areas start overlapping. And in that situation, it really is case dependent. Does the cloudiness from radiation eventually clear up on subsequent scans? So I think what that question is referencing is when after you get radiation to the chest, I'm assuming that's the chest here, the way that you follow the response to radiation treatment is to get repeats chest scans. So you get a CT scan maybe every 3 or 4 months after you get radiation. Now, when you get those follow-up scans, there are normal radiation changes that you can see in the lungs. So if you see a tumor in the lung before you treat it, and then you treat it and you get a follow-up scan and it's a little bit more hazy and cloudy, that's a common thing we see, and that can be very normal. That's a very normal response to radiation. And the real question is the follow-up showing a good response to radiation, or is there something on the imaging that would make you more concerned that the cancer has not responded? Most of the time, when you use radiation for an early stage lung cancer, the area that you treat responds very, very well. In fact, if you look at the outcomes for controlling a tumor that you treat, an early stage tumor that you treat with radiation like this, long term, you see a 90 to 95% chance that the cancer that you treated in that area goes away for good. One of the bigger risks after you treat radiation in a situation like that is that the cancer could pop up somewhere else. And that's one of the big reasons why you get those scans, to make sure that it hasn't popped up somewhere else. But generally speaking, the radiation changes kind of gradually evolve and change, and more often than not, they're normal changes. You just want to make sure that there's not something else going on, specifically in another location.
Thank you, Dr. Lischalk. This is great information. And just to clarify, you said the connection kind of bleeped out a minute. You said 90 to 95% chance. Can you restate that?
Sure. So when we look at CyberKnife or SBRT for the treatment of early stage non-small cell lung cancer, so this is very specific in patients that are not eligible for surgery, so medically inoperable patients, the chance that you get rid of it in the area that you treat for good, which is something we call local control, is typically 90% or more with 3 to 5 years of follow-up. So the trials that have looked at this, there's a very good chance that where you treat it, you get rid of it for good. And so when you're following these with repeat scans, you really, oftentimes you're more worried about it popping up somewhere else than you are worried about it coming back in the area you treated. And so I think that's important to, in the context of the previous question, to keep in mind.
Yes, thank you for clarifying.
Sure.
And it looks like Alyssa has a question. If nodule not near any organ, side effects to CyberKnife besides fatigue?
That's a great question. So the radiation side effects are directly related to where the radiation is going. And the closer a tumor is to certain organs, the more risky it is that those organs could get damaged from the radiation. And every organ in our body has certain tolerances to radiation. There's a lot of complex mathematics that's been done to calculate the tolerance of different organs to different types of radiation. And so when we create radiation plans, one of the big things that we're doing is making sure that those organs that are nearby don't receive excess amount of radiation, placing a patient at unnecessary risk. Of course, we're trying to achieve getting in enough dose to kill the tumor, but at the same time, minimize radiation to those surrounding organs so that they don't, the side effects, untoward side effects don't occur. Now, in the lung, when you, let's say that a tumor is not near the esophagus, just like Alyssa said, it's not near the nerves in your shoulders or your heart. Let's say it's right out kind of in the middle of the lung, far enough away from everything. There is still a chance that you can have a side effect beyond fatigue, and that risk is related to the lung. So the cancer is still in the lung, and so there is about a ring of radiation that's going around into normal lung nearby. So that cancer is in the midst of that lung, and so obviously that, because of that, that part of the lung has been replaced by cancer. It's not really as functional, but around the tumor, there's functional lung. And so one thing that could happen is an inflammation in the lungs from the radiation. Now, more often than not, this is something that does not happen during treatment, but it happens after treatment, maybe 2 to 3 months later. And if that happens, a patient might experience a cough, maybe some shortness of breath. And if we had a scan, you might see that there is some, going back to the previous question, there could be some cloudiness that actually represents an inflammation from the radiation. Now, sometimes we don't have to do anything about this. It resolves on its own. If it's significant enough, we'll have to use things like steroids and sometimes even oxygen to fix the problem. When we use CyberKnife to treat these situations, or SBRT, typically the risk of that happening is very, very low, unless there's already an underlying lung problem. And that would be something that a pulmonologist would have previously diagnosed. So can CyberKnife be done a second time on the same spot? This is similar to the previous question. The short answer to that is yes, it can be done on the same spot in certain situations, but that's a very complicated situation. It really requires a experienced radiation doctor to review. Okay, what can be done to reduce the fatigue from radiation? Great question. So radiation fatigue is can be typically mild in certain situations and less mild than others. It's usually related to the amount of radiation that you're being exposed to, meaning if it's a big tumor that you're treating, there's more radiation exposure, and that has kind of been correlated with more fatigue. But there's a lot of reasons to have fatigue when you're going through treatment. There's a lot of anxiety, there's a lot of stress, you're coming in and out of a radiation facility, you might even be getting chemotherapy during that whole period of time. So it's a multifactorial process. And so it's hard to say if this one thing can help. I would say in isolation, if it's radiation fatigue that's just from the radiation, one thing that I tell patients, which is counterintuitive, is try to stay active. Try to go to exercise, try to go do yoga, maybe get physical therapy. I work very closely with our physical therapists here who actually have regimens to give patients specific to the type of cancer treatment that you're going through that can be very helpful combating that fatigue. And so that's one of the more common things that we do to combat radiation fatigue.
Thank you for mentioning that, Dr. Lischalk. Very good to stay active and partner with therapists and yoga and so on and so forth. I just want to note that we're a little over our time. We want to be respectful of you and your schedule. Do you have time to continue to answer some of the questions, or are you needing to get back
Take a look
to clinic?
at the schedule here. I should have a little bit more time. Why don't we try to get through as much as we can? Yeah, I'm okay.
Perfect.
For a little bit longer. Yeah.
We will take you as long as we have you with us today.
Let's see if we can rapid fire some questions here. Let's see.
Sounds great.
What restrictions are there for treating a location? For example, 16 lesions, now several new ones. So currently being controlled. So probably. Sorry. That's a complicated question. And it sounds like it would be worthwhile talking to a radiation doctor because he or she would have to look at the MRI. For many lesions, sometimes using radiation is not always the best choice. And sometimes using a drug therapy that can get through the brain is more commonly being done these days. But it really depends on the situation and the type of lung cancer that's being identified. So tough for me to answer in isolation. So no, radiation treatment is not considered comfort care. It's there's a difference between what certain institutions call things and what insurance companies call things, etc. But no, radiation is not considered what we would call comfort care. Which needs more lung tissue loss as SBRT or surgery? Oh, okay, great question. So generally speaking, when you do surgery for an early stage lung cancer, the standard is to remove an entire lobe of the lung. Now, in the recent history, in the last 10 to 15 years, what we call sublobar resections are being done, which is removing the cancer, but removing less surrounding normal lung. Okay. There's another surgery that actually just removes the tumor itself. So there's varying degrees of surgery that can be performed for an early stage lung cancer. And it really depends on the situation to determine what surgery you're eligible for. And also it depends on the lung function of the patient. So some patients, if you remove so much lung, they ended up being on oxygen after the procedure. And so that's a conversation you would have to have with a surgeon and a pulmonologist. In terms of radiation, one of the reasons why we use radiation for medically inoperable patients is because it's more tolerable, is because it doesn't really cause as much in the way of putting, it's very rare that you would get radiation that be put on oxygen afterwards. And so when we've actually looked at this in our institution, when you look at the pulmonary function changes before and after radiation, they're very, very minimal. And so for most situations, that's the case. And so that's one of the reasons why we're able to do it even when patients don't have the best lungs. If you have a large tumor treated with SBRT, was only going to the center of the mass, then you had a scopal effect to the upper and lower parts of the tumor that were not treated. So that's a very interesting question. So I can't answer it specifically because it's certainly dependent on the case, but it highlights an interesting topic in radiation oncology called the abscopal effect. What the abscopal effect is let's say you have two lung lesions, and you treat this lesion with radiation, and you don't give this lesion any treatment, and they both shrink. And it's something that we've noticed recently in the last, well, not that recently, but it's something that we've researched more recently to figure out why that happens. And I don't think we have the answer to that yet, but it probably has something to do with the immune reaction to being exposed to different parts of that tumor. So what can happen when you irradiate a tumor, it can get inflamed, and that tumor can expose what we call antigens, which is kind of different proteins on the cell membrane of cells. And when your own immune system goes in and sees those proteins, it can then fire up an immune response. And when it revs up the immune response to this lesion that you treated, those cells are still circulating, and they can kind of circulate over to the other lesion, and you can actually see a response there as well. And so it is something that we're looking at, especially in the era of using immunotherapy so much more. How do we maximize the immune system's response to cancer? Is it typical to have scar tissue in the brain? Is it avoidable? Well, it's kind of having a scar from radiation is very common. To what degree that can cause side effects and changes in quality of life is variable, but it's not uncommon to see just a general response to radiation treatment with or without side effects on a scan. I was told I'm a candidate for surgery or SBRT when my nodule makes movements. I've had 2 lung surgeries already.
You sort of answered it already. That was me. And
Oh,
thank
okay.
you very much.
Sure.
But if you have more to say, that's fine.
Yeah, this is a good question. As time goes on and we've gotten better at treating cancer, lung cancers, you can have multiple cancers that are unrelated occur over time, and there can be different treatments that are used depending on the situation. And so Sometimes you've had a surgery maybe 5 years ago, your lungs aren't as good as they used to be, and maybe you're not eligible for another surgery. In that situation, very often we'll use radiation as a form of treatment. Let's see. More about the possibility of radiation to the pleura. So the pleura is the lining between the chest wall and the lung. And it's kind of a space that cancer can delve into. So we don't typically radiate the entire pleura for non-small cell lung cancer. There are some types of cancers in the chest that we do irradiate the pleura. One actually coming to mind is mesothelioma. But generally speaking, it's a hard thing to do because it's kind of like if you think of your lung, if my fist is a lung, the pleura is kind of surrounding the lung, encapsulating it. And if cancer gets into that area, it has this, it's kind of like a highway to go anywhere. And it's very hard to see where small cancer cells can be. So kind of by definition, once we've found out that there's cancer into the pleura, we're concerned that it could be anywhere. And so irradiating the whole thing for at least non-small cell lung cancer is not standard. Oh, look at this. Where's Lisa?
Lisa.
Hi, Dr. Lischalk.
Hey, how are you?
I'm good, thanks. For everyone else, my legal name is not Leah. That's why Dr. Lischalk knows me as Lissa. So.
Wow, how are you? It's good to see you.
I'm doing well, thanks. Sorry I missed it. I had another Zoom for ALK patients right before this that I couldn't get out of. So
it's good to see you. We've known each other for half a decade.
yeah.
Well, I hope you're doing well.
I am. Thank you. Thanks.
Let's see.
Dr. Lischalk, I think that you've answered all the questions from our participants today.
All right, we did well.
It looks like there, and I apologize, I'm having some connectivity issues. I hope you can see okay. Lots of kudos for the great session, excellent information. We've had a couple of survivors that have had to pop out for appointments, but they've messaged how grateful they are for the information that you shared. These questions come up regarding radiotherapies, what type, what's best, and when. And so this information has been absolutely fantastic. We are grateful that you've taken time out of your busy schedule to join us today.
Thank you so much for the invitation. This was terrific. Really, really good questions. So thank you for the invite.
You bet. Thank you again for taking time out of your schedule to join us, and we hope that you'll come back and see us again soon.
Of course. Bye, everyone.
All right. We'll let you go. Take care. Bye-bye. Everyone, if you'd like to stay on the call, I think Dr. Lischalk is going to pop off and get back to his clinic today, and we can proceed forward with some survivor updates. I am having a little connectivity issue, so I am not able to see your beautiful faces any longer, but I hope that you're able to stay on the call for a while. Did you guys enjoy that?
Much. Yes.
Good. It seems like lots of great discussion. I know that the survivors that had to pop off for appointments were sad to have to leave, and Leah, we're so happy that you could join us and get to say hello to Dr. Lischalk quickly before we wrap up.
I'm so sorry I missed it. Was it good?
It was fantastic.
Oh,
and it is recorded, which we will stop now.